we believe that we can actually change the management of cancer patients by using pretty sophisticated technologies, disruptive technologies that they have in the recent years become available and inexpensive enough, like genomics and next-generation sequencing, to improve patient care. My name is George Vasmadzis. I am a genomicist by training. Actually, I have multiple trainings in my background. I'm an engineer in the way past, and then I became a computational biologist, and I also did bioinformatics and molecular biology. My role within the Center for Individualized Medicine is to be, I'm a co-director of the Biomarker Discovery Program with Dr. John Seville, who is a pathologist.
So I'm Minetta Liu. I'm a medical oncologist in the Department of Oncology here at Mayo Clinic, Rochester. My role in this publication, as well as in the study overall, is a clinical champion. It's trying to identify patients from whom we can learn a lot about their tumor biology in the hopes that we can ultimately translate this into clinical practice.
My name is Panos Anastasiadis. I'm the chair of the enterprise-wide Department of Cancer Biology at the Mayo Clinic. The title of the article is Integration of Comprehensive Genomic Analysis and Functional Screening of Affected Molecular Pathways to Inform Cancer Therapy, to appear in the Mayo Clinic Proceedings.
So we have developed this program where we bring a community of, a multidisciplinary community of scientists and clinicians and informaticians. We encourage communication within this community and understanding of each other's disciplines. At the point that the community is much stronger and synergistic than if it would be individuals. And we think that this community can treat patients better than, let's say, one clinician by themselves. So our mission is to facilitate a rapid translation of these technologies to the clinic. And this particular article is an example of how one could do such a thing. There are a few things that we understood through this work with this article. One is that we're somewhat more fixated in the cancer origin, and we don't see what the cancer state. And as it turned out, genomics technologies are telling us that cancers that they started from the same tissue, breast cancer or prostate cancer, many times end up in a completely different cancer state. And at that situation, it's more important to know what that state is to figure out how to treat a patient.
For me, the relevance of a study like this is the fact that we're not that far from being able to implement genomics and sophisticated analyses and technologies in routine cancer care. And that's what we really need to be doing these days. There's a lot of information out there, and how are we going to harness all of that for an individual patient who's faced with a cancer and trying to make a difference in their lives? It's going to start with understanding the biology of the cancer itself in that patient at that time, and that's what the elegant work that's done as part of this study will help us to achieve. It's putting together great minds with great science to help dissect what's actually happening in the tumor and then help translate that for us. I hope that this is going to give a new definition to multidisciplinary cancer care, because at this point that means the surgeon, the radiation oncologist, the medical oncologist, maybe a plastic surgeon, some medical specialists, all together focused on the clinical aspects of providing care to patients. But what we really need is a multidisciplinary practice that includes the scientists, the cell biologists, the genomicists, etc., again, to pull this all together to get us to what we really hope to achieve, which is precision medicine.
So oftentimes, there are multiple pathways that are identified as potential oncogenic drivers in a tumor. And the challenge is to decide which one of those pathways to use as a treatment in the clinic. In order to make this decision significantly more informed, we generated a ex vivo culture model that we can use in order to test drugs informed by our genomics, and use the information then back to the clinic in order to treat the patients. we can identify in patients that have no standard of care and we do not know what is driving their tumor, we can identify pathways that, if targeted, can show significant response. So in the context of individualizing patient care, I think this approach has a significant promise.
This was a particular case of one individual who had advanced breast cancer. She'd gone through standard therapies that were offering no benefit, and we had an opportunity to try to understand why a cancer we would think would benefit from some of these drugs was not. And remarkably, we were able to translate those findings into an actual therapy for her, and she benefited for a while. It's never as long as we want, but at least it was more time than she otherwise would have had. So it's a good illustration of where I hope to be. I think we all hope to be, and the community, as Dr. Vatsmatsis has brought up, is critical to that success.
In contrast to commercial tests that identified only a handful of molecular alterations in a patient's tumor and identified one or two potential therapies, we used integrated genomics, which identified almost 400 molecular alterations in the same tumor. And then we used an ex vivo drug screen to prioritize those molecular alterations as potential targets for therapy. This approach invalidated some of the potential targets as drivers of this tumor, and at the same time suggested that one potential pathway was a key driver for the growth of the tumor of this breast cancer patient. That's an example in this case. The patient was treated with the new therapy and showed a remarkable response to treatment. This was a case where the patient was misdiagnosed, and the approach that we followed was able to identify the key molecular pathway that was affected in this patient's tumor, and the treatment was able to result in significant response.
So where we see this going? First of all, we have applied a similar approach to a number of patients, and we're learning a lot from those patients, both as far as the complexity of the disease, as well as how to perhaps treat these patients at the right time and perhaps with the right combination of drugs. And we also learn on which drugs don't work, which is also very important, because many times clinicians don't know which drug to use, and they use something that at least our validation shows that it wouldn't work anyway. So what we would like to do in the future is to make this process very robust and very efficient, very fast, and not too expensive. At this point, it does cost at least $10,000 or so to do something like that in a patient sample, and it does take a few weeks. We would like to reduce the times and the expense so that we can make it affordable to use it in the future.
So the next step is validating this approach in a number of patients, a larger number of patients. And to that effect, we have started a project here at the Mayo Clinic through the Center for Individualized Medicine. And it is the goal is to validate the combination of integrated genomics and functional drug screening in patient populations. And we have started with brain tumors. There are very aggressive tumors, those glioblastomas that people have no standard of care really. And we are also focusing on other tumor types like renal, hepatobiliary, lung, breast, and so forth.
So for the science part of this this project, the take-home message is that first of all, we think we need comprehensive genomics to see what is happening, and that single gene assays and even panels do not tell you the whole story, and sometimes they could send you towards a direction that won't work, while comprehensive genomics are really telling the whole story about a particular tumor, and could point to a number of drugs that they can be used or combinations. However, this is still not enough, because even though some of those drugs are proposed by genomics, that doesn't mean that they will work in this particular situation. So the second very important take-home message is that having this functional model outside the patient, so-called ex vivo, that allows us to try those few drugs that the genomics propose, or combinations of those drugs, is really very illuminating on what would work and what wouldn't work.
We keep hearing the terms individualized medicine, precision cancer care, and what does that mean? For many, it's ordering a clinical test available by a commercial entity. You get a report back. It's got a black box, and it tells you what you should or should not do. But that isn't always right, and there's so much more that we can learn from the actual tumors. And it's not just about one report. And then you need to be able to pull that all together. And this is not something that we learned in medical school. So we on the clinical side really need to buck up and learn and try to pull again all of this together for our patients. Precision medicine is going to require looking at tumors and patients in multiple ways and trying to again, aggregate that information, but how do we do that efficiently, and how do we translate that into improved care for our patients? And that's what we are faced with and tasked with, and I think we will rise to that challenge.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.